Hello, everyone. I'm Rose Gerber, the Director of Patient Advocacy and Education for the Community Oncology Alliance. As I like to start every meeting with the most important thing, I want to say thank you all for being with us again. We are all enjoying these advocacy chats so much, and we really appreciate your participation. When we started this advocacy chat series in 2020, our primary objective was to make sure that we were always keeping all of you up to date on any issues that impact patient care. And the majority of our focus is on healthcare policy issues, but we also like to mix it up and bring you a variety of resources and education that immediately benefits patients. And today's topic falls into that category. I'm very excited to introduce Alaina Newell, who is the Director of Education for ReVital Cancer Rehabilitation. And she's going to talk to us about how cancer rehabilitation is a very valuable resource for cancer patients. For those of us who have been through cancer treatment, and for the caregivers, whether they are professional caregivers or family members that were by our side, we know that chemotherapy, radiation, hormone therapy, multiple surgeries impacts our emotional health and definitely impacts our physical health. And when people think about cancer patients, they generally think about the patient in treatment, but survivors, long-term survivors, know that there's many ongoing issues. And what's going to be very special about today is learning that there's resources directly related to cancer rehabilitation that can benefit patients, whether they're newly diagnosed or at the end of life. So Elena, thank you so much for being with us today, and let's get educated.
Thank you so much, Rose. I really appreciate this invitation today, and for all of you for joining us in this conversation. As Rose mentioned, I am the Director of Education for ReVital Cancer Rehab. I am double board certified in cancer rehabilitation, as well as women's health physical therapy. I am Elena, the Lymphatic Association of North Americans certified as a lymphedema therapist. And I also serve on our specialty council for the APTA. Really, how do we elevate cancer rehabilitation as a specialization for all of our physical therapists? I also currently serve as an adjunct faculty at South College and really appreciate this opportunity. So throughout it, we are going to talk about the benefits of cancer rehab. My goal by the end of our presentation is that you will all understand why patients benefit from cancer rehab, understand who is on the cancer care team, especially our rehabilitation providers, understand where does cancer rehab fit into the cancer continuum, and provide you with resources to be able to connect with cancer care specialists for your rehabilitation specialists. So on our next slide, let's talk about why do we need cancer rehabilitation? For me, this picture really tells it all. On New Year's Day in 2016, Arlene went to the hospital with progressive abdominal pain and distension. She left the hospital 4 days later, following a debulking surgery, and was diagnosed with stage 4 ovarian cancer. Wow. She would say that was the day she really learned what it meant to live. 6 weeks prior, she ran a half Ironman, and she had decided to step away from her high-stress job. She wanted to be able to deeper connect with her son and shift her life to more days outside and less living in hotel rooms and business meetings. Over the next 5 years and 2 months, she did just that. Along with her oncology team, her cancer rehabilitation physical and occupational therapists made sure she got those goals accomplished. Arlene needed cancer rehab to allow her to get back to those mountains, to swim, to bike, to run, to travel with her son, see his girlfriend graduate, and have the time, energy, and strength to find peace at the end of her life. Cancer rehab restored her posture, her strength following surgery, and it also helped rebuild her strength, energy, and endurance so she could tolerate 50+ chemotherapy infusions over that time period, while hiking on those mountains and running races. We recognize, though, not all cancer survivors desire to run half Ironmans or make these same goals, but they all have goals. We all have desires to hope to achieve throughout that cancer journey. For individuals with head and neck cancer, maybe it's being able to turn their head to drive safely. Or a woman with breast cancer, how about to be able to hug her son without having pain? And really, for a man with lung cancer, to be able to climb the stairs to his bedroom can be a really critical thing of life. That's why cancer rehab is needed. You may wonder, though, how many people who need benefits of cancer rehab actually get our help? Well, that statistics show us on the next slide that it's 60 to 90% of cancer survivors could benefit from rehabilitation services. That means 10.2 million survivors out of the 17 million survivors in the US have at least one need for specialized rehab. The needs are diverse throughout survivors, and they include areas such as pain, fatigue, weakness, troubles walking and not falling. These impact their ability to participate in their community events like kids' soccer games, attending church, going to the farmer's market, or daily activities simply as getting dressed, making dinner, and their personal hygiene.
Elena?
Yeah, Rose, absolutely.
If I may, just for the audience too, Elena and I have discussed, if I feel there's a question the audience might want to know or that I'm actually interested in as well, we're going to have a little conversation here. When I look at this list of the different basically symptoms, I know again that many people in the audience will relate to some of them. All cancer survivors, the majority have heard of chemo brain, difficulty with daily activities. But some of the other issues that are on here, I think it's very educational. The soft tissue changes, speech and swallowing, which you just mentioned in your earlier comments. Can you tell us, how do patients self-report these? Are the nurses asking this question? How do there's certain things that patients know they're feeling like, oh, I'm really tired or I can't think straight. But some of these others, there might not be as commonly discussed. So if you can talk to us a little bit about that as well.
Absolutely. So I think that's what's really actually interesting about the statistics, that 60 to 90%, these are needs that were identified when they were asked about, not that patients were willing to openly always report them. Did that take extra time on their providers to really tease out? Absolutely. Are there ways and mechanisms we've gotten to be able to stream that a little bit easier? Some of our patient-reported outcome measures are able to address and ask these questions directly. And other times is really what the family members are willing to bring to the table. So the patients themselves may not be willing to admit all these things, but they notice these changes in their loved ones. So things like chemo brain, I think that's a common one that people experience, but aren't always recognizing why it's happening, right? That cognitive decline, but I haven't had chemo yet. Why am I struggling to remember all my different appointments? Why am I showing up late when I was always 10 minutes ahead of the time? So sometimes they identify them, but many times these are just assumed to be part of the normal cancer process. And while we know and we expect some of them to be, how long they last and what they actually impact on their daily life is where rehab really has that place to step in. So one thing we do on the rehabilitation side is we screen and we ask for all these in a couple of fashions. We look at them on our patient-reported outcomes. So as they're filling out and telling us about their general life, we learn a little bit more. We also intentionally perform particular objective measures, performance measures to understand some of these differences. So you brought up the example like soft tissue changes or scarring. We can anticipate those with certain patients more frequently, especially ones who've undergone surgery or they've had radiation. We anticipate that to happen. So we intentionally ask them to move their arms to reach and bend different directions to understand where that tissue is having limitations and could be impacting their normal daily life. Things like speech and swallowing, those are great things we can all observe about a patient. How is their speech? How does it sound? Nowadays with our technology, hey, can you probably have a video or something of you talking to others so we can understand what did you sound like 6 months ago and compare that to where they're at today? I think our pelvic health issues, that's becoming more commonplace to talk about in society, but it's still an area that many are not willing to always express. So monitoring things like how many times did they go to the bathroom during that infusion? Or maybe they're having a heated discussion with their partner and let's find out the root of that. That might be related to changes in their sexual function, or maybe not feeling like such a self-worth, especially as their body has changed through surgery. It's harder to always connect why that's happening and how that's impacting me. I think also to highlight, many of these are physical. We touched on from the cognitive side that's much more of a mental change. We also screen when we're looking at those areas of what other concerns. Maybe it is a cognitive, or is it mental health? Us as a rehabilitation, in terms of physical and occupational therapists, we don't directly assess and work through mental health, but sometimes we can help you identify it and help recognize when maybe we need to get that patient to the right services so they can work through that as well. Okay. One thing when we look at the statistic of that 60 90% have at least one of these impacts, I ask you to wonder which percent of them actually are getting addressed through rehab. Go ahead and take a second. What percentage are actually getting it addressed through rehab? Okay. Our next slide is going to show us it's less than 2%. So that 60 to 90 who could benefit, less than 2%. So let's just say we have 100 people on the call right now. 60 to 90 of us could benefit from rehab, but only 2 are actually seeing rehab. And typically the side effects that they're seeing rehab for are those ones that are very visual or obvious. So things such as having an infection with having lymphedema, or people who have had a fall that's resulted into a hip fracture. Those are the ones that are getting sent to rehab. For some of these other changes, their scarring, their cognitive changes, their arthritis or pain, those are not always being addressed at this time point. When we think about that, that is a large number of our survivors, and we want to really connect. So put yourself in those shoes for a moment. Assume you're not a 2%er. Assume you're part of that rest of the group. How would that change if you require an extra hour to do your morning toileting routine? What if your partner had to help you put on compression socks every morning and take them off at the end of the day? Or maybe your son had to come over to make sure you were safe in the shower.
Wow.
I know this would hugely impact my ability to do my current job. My travel would get stunted. I know trying to put my kids' shoes on, trying to bend down onto the floor would definitely be a challenge. Or recently at Halloween, how about passing out that candy? Would you feel confident to reach forward, pick up some pieces, drop it into those buckets in the dark or you're like low lighting? All of these things may seem small, but they are what makes our life more colorful and unique. So looking at that and taking in those considerations, we think about Arlene. Her life looked dramatically different in those first 3 weeks recovering from surgery. Her adult son did move in temporarily to help her out again. He had to help her get in and out of bed, and they finally quickly decided she wasn't going to do that. So she was sleeping in the chair the majority of the time because they couldn't get that coordinated together. And her neighbor would come over to walk her dogs because she didn't trust herself to hold their leash. But really what limited her was trying to bend down to pick up their poop, right? The small things that we don't think about of impacting a walking a dog. So for her, those were her first goals. She wasn't robotically thinking about her big races. She was thinking, how do I do my day-to-day and really recover out of the surgery? Like I mentioned in rehab, we definitely worked through, address those, get her straight back up doing these daily activities. But we also know her rehab didn't just stop there. I had mentioned she'd had 50 plus chemotherapy infusions. So on our next slide, we're going to highlight where cancer rehab is within the cancer continuum. And quickly, you're probably going to see we have a role throughout the entire sphere. We definitely work with people in the community so we can help with those prehab, help them understand, have they gone through their cancer screenings, help with some lifestyle education, reduce our smoking sensations, increase their physical activity and potentially lose weight to help reduce those risk factors related to cancer. After somebody's been shortly diagnosed, we also do a lot of preventative work. We're trying to work to prevent future disabilities. So understanding what their daily life looks like now, knowing their cancer treatment, what's coming down the road, and how to anticipate what areas may have life be impacted. So we can start to address those now. We can optimize their ability to really tolerate what's coming down the road. And as they go through their cancer treatments, no matter what it is, surgery, radiation, chemotherapy, immunotherapies, we work on 3 different components of our disease classification. We really focus to help restore function, meaning knowing they've had a decline from their baseline, help them get back to those things, get back to getting down to tie those shoes. We also support them. We understand some of them may not be able to improve their status as they go through treatment, but can we help them from further decline as they're undergoing treatment? Once they've completed their active treatment cycles, really looking, do we restore? Can we get back to some of those higher level activities they wanted to do and understand the little nuances while still supporting those that we know some of their function and their body impacts are not going to be able to be reversed. We know following radiation, tightening of the tissue We can't make that 100% reverse, but can we change how they functionally are able to do their daily life? And then as time goes and we're following up with them, those same principles still maintain. As our patients transition towards palliative care of end of life, you see I've added in our fourth principle of cancer rehabilitation, being palliative. So we still work in that supportive nature and helping maintain their function, but we also play a large role to help reduce their symptom burden and help improve their quality of life. That can be as simple as understanding better positions to lay in bed or adjusting their pillows, helping their caregivers understand this new and changing role, making sure they are taken care for as well, having better body mechanics, understanding rotations. How do we prevent additional complications, potentially as bed sores? Or why is it important to make sure they're sitting up and reduce potential cardiovascular changes or respiratory difficulty then? So we have a role and we utilize our 4 pillars of cancer rehab throughout the cancer continuum. We just shift and change our focus based where the person is. And that's one thing you'll find with cancer specialists in rehab is we understand this big continuum. We understand the treatments they're going through. We go through additional training so we're aware of these different pieces, and then we can be more meaningful and target where they're at and where they're wanting to go. So if we look at this, and maybe y'all have seen a different picture, but whenever I see the cancer continuum, it's always linear, right? We go from one step to the next. It's always a straight line. But I'd say we all probably realize it's linear. It's not linear. It's up, it's down, it's all around, it circles, and we sometimes go back and forth. Mm-hmm. And so I sometimes like to think about it more like a bouncing ball, right? So on our next slide, we're going to think about that bouncing ball idea. And go ahead and take a moment and imagine with me. Get a nice rubbery ball in your hand. Maybe you're just red or blue, purple. Maybe you got some sparkles going on. And give it a nice firm bounce on the ground. Let it bounce and come back into your hand. This is what we see when our patients are robust or they have our higher performance statuses. They're able to come back from that bounce. They're able to return from their stressor back to their prior level of function. And we do see that, but we know in cancer treatment, rarely is there just one bounce. Rarely do they just have one stressor. Most of the time, they may have multiple interventions. Maybe they have surgery and chemotherapy, or chemo and radiation, or a different combination of those. So they have that multi-stressors that go on. We intentionally try to spread these out, right? We provide time between one to the next to allow them to have that recovery time period. But not everybody recovers at the same rate and speed. And for what we all know about cancer, we do have to keep on a timeline. We need to keep that treatment moving forward to best eliminate these tumor cells, to best kill them down. This time makes a big impact. So if we think about that, not everybody is going to rebound to the same level as they were when they went into treatment. We see this especially for our people who are more pre-frail or have a lower functional capacity. And how high that ball bounces back up definitely is going to change, and it's not going to be the same each time. The more they get hit, the more stressors they have. If they don't bounce all the way up, we see this decline over time from robust to pre-frail, frail, and potentially also resulting in disability, requiring a dependence of increased caregiver. So if you think about this, I want you to go ahead and go back to that ball concept. You bounce your ball and you think about how can I make sure that ball bounces back up all the way to my hand each time, even as different stuff's going on. If we think about that, how could you make sure your ball bounces higher? How could you think about making sure your patient stays out of the hospital because they have a higher functional status? What about, could they tolerate their cancer treatments better? And how would that look from your side of, could I change the trajectory of my patient? How would they look when they come in for the subsequent visit? So you may wonder, what is that magic trick to how do we get that ball to bounce a little bit higher? Well, I'd argue cancer rehab is a big piece of that. We help with that performance status. We help bring back up that functional capacity to a higher level. We really help reduce that burden of treatments that may stack up over time. On our next slide, it dives into the cumulative benefits of cancer rehab. And I like to say benefits or outcomes with a capital O. We work to improve their mood, their cognition, their social participation, going out in their community and doing things, their nutrition, their energy levels, and their overall function. We reduce that symptom burden of their disease, and we also build that tolerance and ability to tolerate more cancer treatments.
Elena, what does social vulnerability mean? I don't know what that means.
We've already talked about that. It was like, what's that piece? So where that came is, when we look at social vulnerability, this is a cue in recognizing, are we able to have the ability to integrate into our communities? So socially being that interaction with others, vulnerability is, are we at risk or are we vulnerable to not being able to have that capacity? So you may be alive, but are you going out to church? Are you having lunch with your friends? Knowing that extra community interaction is definitely important in our lives, but that is something we see as cancer treatments go. People reduce their circles. They don't spread their wings as far, they don't go as far outward. In cancer rehab, we work to really focus on that. So not just that day-to-day, but really how do they interact in their community and doing the activities they want. So being more vulnerable makes it more difficult. Cancer rehab, we build that so you're not quite as vulnerable as you may have been in the past.
Thank you.
Yeah. When we look at this, our body of cancer rehabilitation literature has definitely grown over time and is definitely getting stronger. Many probably don't know, but cancer rehabilitation as a specialty has been around for just about 40 years. That's when Dr. Dietz really started laying those 4 pillars of cancer rehab out for us. And this body of literature has continued to grow at an exponential curve. So on our next slide, I'm going to highlight just one study that came out of our program. So at ReVital, we have multiple different therapists throughout the community. This study was done particularly within our Dallas market. And what I was looking at is our community-based therapists, both occupational and physical therapists. What we did is we looked to assess how our patients' function changed with rehab. So we looked at that through their eyes as well as their performance status. We administer one of our outcome measures we administer to our patients is the PROMIS measure of global health, both physical and mental. And then we also perform measures to see how do they move and perform in the clinic. So our patients reported that they had an overall improvement in their global physical health. These are questions such as, are you able to do your normal daily tasks, including walking around your home, caring for yourself? So some really global basic things. We also include this measure, what their fatigue levels are, how much pain they're experiencing, are things that get incorporated in that measure. This participation in social roles and activities. This is a 4 question. One targets how their relationships, interactions are with their family, one around their friends, another with community groups and organizations, and their overall satisfaction with this. So not just what they can do, but how do they feel about that ability to interact. So we saw improvements in both of those main domain areas, as well as the performance measures of their grip strength and a reduced fall risk, which we measured through the tug. Grip strength, while yes, it's important to have strong hands, grip strength is one of those really strong measures we've seen over time that helps us understand somebody's overall strength. So not just in their hands, but is a good screening measure for overall strength. And then the fall risk, I think we all care about this. We often ask those questions. Have you had a fall in the last 6 months? Have you had any near falls? We know people who fall have a greater disability, more likelihood of having hospitalizations or additional complications like those fracture risks that I had mentioned, that oftentimes that's why they get to rehab. So realizing, can we reduce that burden? They're more likely to be able to tolerate their cancer treatments or have a less impact of that long term. When I look at Arlene, obviously we saw that she had these benefits and these changes. She also had other benefits that we may not have captured in here, such as she kept running triathlons and she completed another half Ironman 5 months before she died. So she was one of those that when we see these, it's not just a number, it's not just a statistic of those improvements, but it really translated to making sure she was doing the things that were important to her. So let's look at how this kind of fits on the big cancer continuum. On the next slide, I'm going to highlight just 3 areas of cancer standards and guidelines. In 2013, the Institute of Medicine reported delivering high quality cancer care report demonstrated that cancer rehab should be part of the cancer team, as well as we've seen from the NCCN, the National Comprehensive Cancer Network. They really promote rehabilitation services in 3 domains: for survivorship, cancer-related fatigue, as well as adult cancer pain. And those are areas that are definitely high focuses for us. And in 2020, the Commission on Cancer directly pointed out rehabilitation services in the standard 4.6, and recognizing this isn't just a policy about referring to appropriate rehabilitation services, either on site or by a referral, but it also required having inclusion criteria of a functional assessment. You needed to define the types of rehabilitation services you were connecting patients to, as well as their actual location. So how far or appropriate was that within your community? And they really emphasize the importance of having rehab professionals to attend cancer committees. We see this being spread throughout the country, and that involvement and the participation, allowing the rehab professionals to really chime in more on what is the patient's performance status, what is their functional capacity at the moment, and how has that changed throughout their continuum. So it's really helped us raise the bar for all of us to be more mindful, more strategic on our holistic care. Where I think we always need to keep working is how does that work throughout the cancer continuum? So maybe we call it out in survivorship. How do we integrate those services at our earlier time points at the prehab before any disabilities have occurred? When we look at these, I do like to think of recognizing the diversity of what we all have to cover now. These standards, I know it feels like they're not getting smaller. There's probably more domains and areas we're having to address for our patients. And so just realizing and recognize that complexity, we all know it takes a team, and it's hard for us to each do it ourselves. So the next slide, there's a quote that I really appreciate from Dr. Atul Gawande that he wrote out in the checklist manifesto about how to get things right. Realizing the volume and complexity of what we know has exceeded our individual's ability to deliver benefits correctly, safely, and reliably. So that's where partnering together and working cohesively will really help us to achieve these missions, to achieve these different standards, but really importantly, to achieve and impact patients' lives like Arlene. We all work in our own teams. We realize there's a large team in the cancer care team. So on the next slide, I just want to point out who all is on there and where cancer rehabilitation clinicians come in. Those are patients in our center, and we're all surrounding them. We all have these really vital roles, from physicians to nurses, pharmacists, physicians assistants, palliative care, and also supportive and spiritual services. Looking at that slide, understanding who is rehabilitation services, I'm going to dive into a little bit more on the next slide. There's many of us who work on our team, really focusing on that occupational, physical, and speech therapist I'm going to do for a moment. These 3 are ones that we work primarily in all different care settings, from acute care to skilled nursing to outpatient. Some of the more robust cancer rehab programs you're going to see will include all 3 of these disciplines. We all work with patients at different standpoints, and some patients may need just one of us, but they also may need all 3 of our services. On the next slide, I had mentioned cancer rehab specialists. We've all heard of therapy, probably in some light, whether for your knee or following a stroke. What makes cancer rehab specialists unique is we have that greater knowledge of their cancer care continuum. We understand what medical interventions they've gone through. We're building those relationships through our cancer communities and our committees, working with and alongside of you. So we're able to provide safety. We're able to use certain precautions and contraindications, and we really focus back into what's happening on their daily life. We work within our own teams as well to talk about who's going to help different components of their care, but we also screen for late and long-lasting side effects. So knowing I may see them today, but where I may need to see them in the future, and helping them understand that piece of it. It's not just in this episode of care, but how I'm going to help care for them long-term, just like our physician partners do. So I know we're getting close to the top, so I just want to take a moment and reflect on who Arlene was. I mentioned what her goals were. She wanted to attend her son's girlfriend's graduation. So the next slide, we have 4 pictures that kind of really highlight her big successes. It highlights her being able to attend that graduation during her chemotherapy. She was originally from Hawaii, so getting a couple big trips back to the Big Island was really important. She actually ran a marathon, the Honolulu Marathon. It's really made that happen. Being time with her son, right? That's why she actually changed her job before she was even diagnosed with cancer. And that was a critical piece. So they kept taking pictures of all the different places they went and did things together. And I mentioned she ran that half Ironman not all that short before her death. So really, at the end of the day, she was able to achieve her big life goals. And she was able to do that through over 5 years of having stage 4 ovarian cancer. She accredits her whole team, her whole cancer team, to really making sure she was able to do this. And she consulted all of us in different avenues for different pieces of her life. So you may not spend time focusing on how to marathon train, but that's something, yeah, we can do and help provide that to her. You may wonder where we work. I said we're all different care settings. On our next slide, I'll highlight the two main ways that we see patients and outpatients, primarily through people come into the clinic and we're working with them in our clinical space. But we also provide tele-rehab, just like you provide telehealth, where we can meet them in their home through the computer, understand their, progress their exercise program, but also providing that maybe more safe environment they may need from time to time in that space as well. Another question we often get in cancer rehab is, does medical insurance cover? Yes, we are a therapy just like you may see after a stroke. And so on our next slide, we'll really show that we are physical therapists, occupational speech therapists. We bill the same codes like we would, no matter your different diagnoses. So recognizing it's not unique in that standpoint, your patients will still have that insurance coverage. And our next slide, I'm going to show you at the moment where cancer or ReVital Cancer Rehab is located. So we are currently in 21 different states with 24 different markets. That works out with, Texas is a large state, so we have multiple markets, Dallas, Austin, as well as Houston. So we are able to cover patients in quite a bit of the country. We recognize, though, that we may not be in your particular backyard. Our mission, ReVital, as well as cancer therapists in general, is really providing these comprehensive services and ensuring we help throughout the cancer journey. So if we're not located in your space, by all means, let us know, because we are continuing growing network. But an additional resource you can find on the next slide is the APTA, the American Physical Therapy Academy Association, the Academy of Oncological PT. There is a button towards the top there that says for consumers, and when you click on it, it gives you a link to put in your information to find out where we are in your community. So board certified specialists throughout the country, where's the closest one to you? This is a great resource to be able to connect. I mentioned I'm on a specialty council with this academy, and our goal is to really ensure our clinicians have those high level skills that you can feel that trust and build with these type of rehabilitation therapists. Okay. So my next slide is just a conclusion, just a thank you again for this opportunity, and let you provide my contact information if you need additional information or any information you'd like to know about cancer rehabilitation.
Thank you, Elena. I really learned a lot today. I really want to thank you. This is very interesting. I'm sure that our audience learned a lot too. And I also, now that I see Amanda Hodges' name on there, I also want to thank her. She was one of the first persons who made me aware of the work that you do. And she was one of our former CPAN chapter advocacy leaders. So thank you. As I always say, it takes all of us to learn more. And if I can also go on to the next slide. Thank you again, Elena. You did a great job. Next month, we're also going to be learning something very new to many people. When a cancer patient gets diagnosed, in a perfect world, the only thing that cancer patient would need to do would be to focus on their treatment and their recovery. But as we all know, it can be so many things that cancer patient has to start dealing with, from financial toxicity, managing healthcare, worrying about their jobs. And we have an incredible guest next month. This is Monica Bryant, who's a chief operating officer from Triage Cancer. Some of you may be aware of Triage Cancer. These partners are both attorneys and have done such great work in this particular space. So please join us next month, Wednesday, December 14th, to learn about the legal implications of when a cancer patient is diagnosed with cancer. Thank you all, and enjoy the rest of your day. Thank you again, Elena.